Now we're going to do a quick 20-minute review of management of metastatic breast cancer. So Dr. Erika Hamilton will be walking to the podium. Dr. Hamilton is Director of Breast Cancer and Gynecologic Cancer Research, Sarah Cannon Research Institute, Tennessee Oncology. Thank you.
Hello, everyone. Just metastatic breast cancer in 20 minutes.
Right.
It's going to be so easy, guys. Okay, so I'm trying to divide it into, now we really have 4 subtypes of metastatic breast cancer. So disclosure, just say I take no funds personally from pharma, all our research funding. Okay, so we're going to talk about hormone receptor positive, HER2 positive, HER2 low, which is our new little caveat here, and then triple negative. So let's start first with hormone receptor positive. So this was Mona Lisa 2. This looked at ribociclib in combination with endocrine therapy in the first line setting. Recall we have pretty decent overall survival data in the second line setting across CDK4/6 inhibitors, but we really haven't had a ton yet in the first line. And so let me compare and contrast here for you. So with ribociclib now, we see a 12.5-month difference with adding CDK4/6 inhibitor in the first line compared to not. And so there's 2 things that stand out to me here. 1, that's an over 1-year improvement in overall survival. And 2, our overall survival for metastatic hormone receptor positive disease is officially greater than 5 years now. So that's a pretty big deal for our patients. So let's look at Paloma 2 and Monarch 3. So our other kind of counterpart studies in the first line setting for ER positive disease. You can see on the left, we saw this data relatively recently, and it was really disappointing. We did not see a benefit for palbociclib in the first line setting, which was, probably a surprise to a lot of us. And then on the right, just recently at ESMO in Paris, we saw some overall survival data for Monarch 3 with abemaciclib. And recall that this also was the latest trial that started enrolling, so therefore it's the most immature. And although we see about a 12.5-month, same kind of magnitude of benefit, and you see the p-value here at 0.03, the way their statistical analysis was done, this actually wasn't statistically significant. So we can get into the details of whether you're going to call that different or not different, but that's where we sit right now. So in terms of toxicities, I think we're all pretty familiar with this. We certainly see neutropenia across the class. We have about double the grade 3/4 neutropenia rate with palbociclib and ribociclib compared to abemaciclib. But remember, it's also still quite common with abemaciclib. So essentially, grade 3 neutropenia for palbociclib is around about 70%, and you get about 35, et cetera, with abemaciclib. Abemaciclib, however, has a little bit more GI toxicities, diarrhea predominantly, a little bit of nausea. And then ribociclib is also the drug where we have to monitor QTc interval. And so in Tennessee Oncology clinics where we have cabinets filled full of EKG machines, that may not be very hard for us, but there are some community practices that don't have access to EKGs, and so that can be a challenge. So in summary, palbociclib right now is the only CDK4/6 without a survival benefit. And uniformly, it was the one I'm guessing that the majority of us in this room were using. Monarch 3 has the shortest median overall survival follow-up, currently showing about 12.5-month difference, but it's not statistically significant yet, and we are going to get one more update as this data matures. All 3 phase 3 trials with ribociclib demonstrated an improvement in overall survival, but head-to-head comparisons really are quite lacking here. There is the Harmonia trial that's going to look at ribo-palbo with a HER2-enriched subtype, but obviously there hasn't been a massive appetite to try to put the CDK4/6 inhibitors against each other. So I personally am starting my new first-line patients on ribociclib now. There's certainly, caveats to that. I really, have used all 3. There are certain patients that do better on abemaciclib, maybe people that have a low neutrophil count to begin with, et cetera, maybe people that have brain mets. And ribociclib certainly has the data for premenopausal patients, but palbociclib's a lot cleaner in terms of drug-to-drug interactions for older patients that are on a lot of medications, and we don't have to monitor QTc. I'm not switching any of my current patients that are doing well on palbociclib to ribociclib. So what's coming? This is BRE 389 because I just can't help myself but to tell you about the clinical trials that we have here at Tennessee Oncology. So this is post-Monarch. This is essentially a trial randomizing patients that have already been treated with CDK4/6 and endocrine therapy in either the adjuvant or the metastatic setting and subsequently progressed to either fulvestrant or fulvestrant with abemaciclib. So really kind of asking that question of CDK after CDK and switching to abemaciclib. So let's move to SERD. This is selective estrogen receptor degraders. I know that many of you are quite familiar. We're seeing data kind of come out about this, and there's probably about 13 of these in development across multiple companies. You can mentally put them in the fulvestrant bucket in terms of how they work, but they're pills, and they're certainly more potent than fulvestrant. So this was Emerald. This was the first data we saw from Dr. Bardia looking at elacestrant. And I'll highlight that all of these patients had already seen 1 or 2 lines of endocrine therapy for metastatic disease, and they had to have had CDK4/6. So unlike some of the trials that you'll see where it's a little bit of a mixed bag and some people hadn't had CDK4/6, which really influences outcome, here everyone had seen CDK and they had at least had 1 line of therapy. And they were randomized to either receive elacestrant or investigator's choice endocrine therapy, of which most people got fulvestrant. I'm also going to highlight here that there were essentially about 500 people on this trial. So progression-free survival was statistically significant, statistically different in the intention to treat population for PFS, but numerically the difference was 1.9 versus 2.8 months, so about a month difference. And if we enrich for patients that have ESR1 mutations, we were able to kind of show a bigger magnitude, 1.9 versus 3.8 months. So although this study was positive, a little bit disappointing that we weren't just doing better for our patients. And what stands out to me in these curves, particularly in the top left, is it really looks like there's about 40 to 50% of patients that progress at their first scan no matter what they get. They're just not endocrine sensitive anymore. And we're not smart enough in the clinic yet, post AI and CDK4/6, to figure out who are the people that are going to go on to getting more endocrine therapies and do well for years versus who are the people that have endocrine resistance and aren't going to get benefit of these therapies. So it's really tough, if you just look at the bottom of that curve, elacestrant's clearly outperforming other endocrine therapies. It's just a lot of the curve is kind of wasted in people that ended up having endocrine resistant disease. So what about the other 2 bit of bummers? These were oral SERDs that were reported at ESMO just in September. This was amcinestrant and giredestrant. Both of these were not statistically different. You can certainly see on the top that these are the all-comers. On the bottom, patients that have ESR1 mutations, so you do start to see a little bit more spread there. But I'll also caution you that both of these trials were smaller. They only had about 300 patients in them. So if you think about a 500-patient trial versus a 300-patient trial, especially where, again, you're losing about half of those patients off the top of the curve, it really becomes pretty tough to see differences with these compounds. There's also some subtle differences about people kind of guessing whether the dose of some of these were quite right, and that's a variety and probably a whole nother topic of conversation. So what are the oral SERDs like? We've been using them in our phase 1 unit for years now. Gastrointestinal side effects, we can see this. They're a pill. It's really not bad. I would say probably about 70% of my patients need nothing, and maybe about a quarter of them take PRN antiemetics, not nausea, et cetera, like you would think for chemotherapy. We also have a handful of compounds that can cause some grade 1 bradycardia, which is interesting. If you have a resting heart rate of 70, you're probably going to have a resting heart rate of 55 when you're on drug. Stop the drug, it goes away. If you race them around the nursing stand or you send them on a hike, their heart rate will come up. They don't pass out or anything. It's not really clinically significant. We can also see some fatigue, like any cancer treatment, some hot flashes. And then we also have one that has a visual disturbance. And a lot of excitement has been made over this. This is not antibody drug conjugate eye toxicity. This is actually a movie theater phenomenon. And what I mean by that is, if you recall, when you go out of a movie theater and you first go from dark to light, your vision's a little bit waffly on the edges. Lasts about 10 seconds, goes away. It only happens when they turn on the light or turn off the light. Doesn't interfere with reading or driving or anything. So this is BRE 384, it's Serena 6, and this is exactly what Kevin was talking about, except now we're talking about first line. And so essentially on the first part of the study, we're just enrolling patients that are on first line aromatase inhibitors with palbociclib or abemaciclib. And they get ctDNA monitoring. And so they'll go along for months and get ctDNA monitoring and maybe never pop positive for an ESR1 mutation. But if they do, then that's where they enter the active part of the study, asking that exact question that Kevin was talking about is, do we do any better for a patient by switching them to an oral SERD with CDK, or do they do the same and they should just stay on their AI and CDK? So to be clear, these are people that don't have progression, they're just popping positive for an ESR1 mutation. So asking that question is an early switch, help our patients or not. And then this is Serena 4. This is our first line study, oral SERD plus CDK4/6. I really can't think of a reason why most patients shouldn't be going on these. Certainly, none of the trials have showed oral SERDs to be inferior to any of the agents we've had, and we certainly have some trials that show them to be superior. I'm particularly excited in these earlier settings where endocrine resistance isn't an issue, what this is gonna look like. And then we also have adjuvant giredestrant. So instead of being on tamoxifen or aromatase inhibitor, you potentially can get an oral SERD at that point. So definitely a lot of options. This was TROPiCS-02. This is sacituzumab govitecan for hormone receptor positive disease, and it's essentially randomized against treatment of physician's choice. Remember, all of these patients had already seen chemotherapy, and in fact, at least 2 lines of chemotherapy for hormone receptor positive disease. And what we saw was the ADCs, once again, are outperforming chemotherapy in terms of progression-free survival as well as overall survival. So let's move to HER2 positive. This is an oldie but goodie. I think you're all familiar with trastuzumab, tucatinib, and capecitabine. I think that we're probably really using this in the so-called third line setting right now. Positive trial in terms of PFS, overall survival, as well as PFS and overall survival for patients that had brain mets. So this is BRE 383, building upon HER2-CLIMB. This is HER2-CLIMB-05. And it's looking at adding tucatinib into maintenance in the first line. So when you're giving your 6 to 8 cycles of THP for first line HER2 positive disease, and you're gonna drop your chemo out, and you're gonna continue HP and maybe add an endocrine therapy, this trial randomizes patients at that point when they're dropping their chemo out to potentially adding tucatinib in. So I think a really great strategy, kind of to maybe even divorce tucatinib to the capecitabine backbone, but also really exciting to give it earlier and see whether we may be able to prevent some brain mets. So trastuzumab deruxtecan, another one that I'm sure you're quite familiar with. You can't see many breast cancer articles that don't include trastuzumab deruxtecan these days. So this is an antibody drug conjugate to HER2. It has a drug to antibody ratio of 8 and has very prominent bystander activity. This is DESTINY-Breast03. So we already had trastuzumab deruxtecan approved in the third line, and this was the second line trial, essentially randomizing trastuzumab deruxtecan or what our second line standard therapy at the time was, TDM1. And what we saw was a curve that you could drive the truck between. So hazard ratio of 0.28, which is the best hazard ratios we've seen since trastuzumab days in the 1990s. So quite impressive showing trastuzumab deruxtecan beating TDM1. And so based on this, we now have approval for trastuzumab deruxtecan in the second line setting. So what we're really using is taxane trastuzumab pertuzumab first, trastuzumab deruxtecan typically second. If brain mets, you could be using tucatinib. And then at least in my practice, I moved to tucatinib in the third line. And then we can always go back and re-look at TDM1. So what are our side effects? We certainly do get count disturbances with trastuzumab deruxtecan. I think we're all familiar with needing to monitor for ILD pneumonitis, but the most significant and frequent side effect is actually nausea. And so in a lot of the trials, there were not prophylactic antiemetics, and so we had pretty high nausea rates, about 75% of people having nausea. It's now classified as a moderately emetogenic regimen, and so depending on which institution you're at, that's an either 2 or 3 drug prophylactic antiemetic. So in my clinic, I use dexamethasone, ondansetron, and an NK1, and people do a lot better on that. You can always peel things back if they're doing well, but then you don't have people that are really angry at you because they feel miserable. So what trial do we have now? I think there is great interest in moving trastuzumab deruxtecan to various other places of therapy. This is DESTINY-Breast07, and it's incredibly complicated, but I'll summarize it as TDXD combos in the first line. So we've got TDXD with immunotherapy, we've got TDXD with pertuzumab, we have TDXD with tucatinib, and so essentially an opportunity for your patients to get trastuzumab deruxtecan earlier than they otherwise would with what's available standard of care. Also recall there's no arm that isn't getting trastuzumab deruxtecan, so I think it's really easy sell for patients too. And then this is also just to show trials that we have and are coming here. So we have TDXD combinations in first line. We have TDXD versus TDM1 for adjuvant disease, so Catherine-esque. We have TDXD with pertuzumab versus THP, so trying to dethrone our first line treatment. And then we have TDXD in the neoadjuvant space. And I've had a few people on these trials for neoadjuvant, and they're doing really well. Lots of pathologic complete responses. And then we also have the Compass RD trial, which is looking at TDM1 with tucatinib for residual disease, so kind of trying to improve upon Catherine. So let's go to HER2 low, and there's essentially one big story here, and it's still on the trastuzumab deruxtecan theme. So this is DESTINY-Breast04. It was presented at ASCO in 2022, and it was the standing ovation in the plenary. So we essentially took patients that were HER2 low, and what is HER2 low? Well, it's not 0, and it's not positive, and so it's anybody that falls in that bucket that's a 1+ or a 2+. And randomized either to treatment of physician's choice chemo, good chemo that we give to these patients all the time, or trastuzumab deruxtecan. Everyone here had had 1 to 2 prior line of chemotherapy in the metastatic setting, so they were not first line. And what did we see? So the majority of patients were hormone receptor positive in the trial, about 90% actually. And it's true that more hormone receptor positive patients will be HER2 low than triple negative patients. But essentially an improvement of almost 5 months in terms of progression-free survival and an improvement in overall survival essentially from 1.5 years up to 2 years. So pretty impressive results for patients that don't even have that good of HER2 expression. So in summary, there really was not a new safety signal, but across the board, patients that had HER2 low breast cancer benefited, and this was approved in August of 2022. The big catch here is we need to start making sure that we're capturing everybody that's HER2 low. And all of our notes are guilty, right? You say ER positive, HER2 negative, and now the question is, what's negative? Is it 0? Is it 1+ or 2+? And then for our patients that haven't had a recent pathology sample, a lot of great pathologists are telling me, Giuseppe Vialli from Italy is one of my favorite. He's like, I put the slide on and I look at it and there's not any HER2. And so I yank it off and I call it a 0. And he's like, but now you really need to look. You got to move the slide around and see if it's a 1+ anywhere. So I think that really argues to the fact that we should be getting path reviews for our patients that are 0s, or maybe even fresh biopsies in certain circumstances because we don't want to miss out on this. So what do we have in trials right now? This is a very similar slide to DESTINY-Breast07, except now it's called DESTINY-Breast08, and it's first-line TDXD combinations for HER2 low. So we've got TDXD with AKT, TDXD with endocrine therapy, TDXD with capecitabine. And so again, an opportunity for patients to receive this in the first-line setting. And then the big question is, how low can we go? So what is it about 0? Is there really a difference between 0 and 1+? We all know that an IHC of 0 does not mean no HER2. It's really less than 10,000 copies of HER2 on the cell surface, and so there are still HER2 out there. And in fact, these are the responses on DAISY of patients that had an IHC of 0. And gosh, that doesn't look too bad. That looks better than what we do with some chemo. And so that's the question that we next need to be asking is, A, is IHC the best way to test for HER2 now with this drug, or could we just be giving it to our 0 patients and everyone? So let's finish with triple negative here. This is the ASCENT trial. It was BRE 298 here in our clinical trial lexicon, and it was sacituzumab versus treatment of physician's choice in metastatic disease. You can see progression-free survival and overall survival, definite benefit of about PFS of 4 months, and overall survival even bigger, about 5.5 months over chemo. So the moral of the story is our single agent chemo is not as good as we thought it was. And then this is BRE 394. It's currently open. This is a first-line trial, and this is for patients that are PD-L1 positive, and it's essentially in the first line randomizing to chemo pembro or saci pembro. And BRE 395, quite similar, first-line triple negative. Now patients are PD-L1 negative, or they've already had PD-L1 for neoadjuvant treatment, and they're getting saci or treatment of physician's choice chemotherapy. So again, another trial where you get to access an already approved agent earlier, potentially. This sacituzumab is not going to be the only TROP2 antibody drug conjugate for long, I don't think. This is Dato-DXd. So this is another TROP2 antibody drug conjugate on Daiichi's platform, essentially. So kind of the Enhertu trastuzumab deruxtecan backbone. This is BRE 396. Again, this is upfront Dato-DXd TROP2 versus investigator choice chemo. And then this is a HER3 antibody drug conjugate. So you're starting to think to yourself, wait a minute, how many antibody drug conjugates do they have? Well, we have HER2 with trastuzumab deruxtecan. We have a TROP2. This is a HER3, and I think the story for this is going to be very similar, where you're not going to have to necessarily be HER3 positive or have a ton of HER3 expression to have a response. So this is actually an IIT that we have, BRE 354. We've already completed the first half of it, where we enrolled triple negative and hormone receptor positive, agnostic to HER3, and we're essentially kind of looking what groups we want to go into an expansion with, dependent on who has a PFS of longer than 6 months. But what's really interesting is the bottom. And interestingly, our IIT was the only trial that was uniquely poised to answer this question, which was post-trastuzumab deruxtecan. Can you go back in with a similar ADC payload to a different target, and does it do just as well? So now we currently enrolling, we've got 20 spots left here. So HER2 positive disease that's already seen trastuzumab deruxtecan, now getting HER3 DXd. So in summary, I think oral SERDs still have the potential to replace aromatase inhibitors. I am not dissuaded from the 2 negative trials. We've already seen a press release about 4 weeks ago that camizestrant in SERENA-2 was also positive at both the 75 milligram as well as the 150 milligram dose against fulvestrant. So we've got 2 positives and 2 negatives. No doubt in my mind that these drugs work. We have 20 to 30 patients in our phase 1 unit that have been on oral SERDs that progressed on fulvestrant in 2 months that have been on it for a year or 2. We just have to get smarter at picking who they are. Efficacy of tucatinib and trastuzumab deruxtecan, certainly we're going to be seeing these compounds go into other lines, not just later line metastatic disease. Certainly, we're going to have TROP2 antibody drug conjugates, and really whatever ADC we put against chemo, we're kind of knocking the ball out of the park here. And then, as always, appropriate patient selection and trial design is crucial. It's not necessarily the drug's fault if it's negative. Sometimes we didn't ask the right question. Thank you so much.
Thanks so much. Any questions from the audience? Can you speak to how often you repeat biopsies on your patients in the metastatic setting?
Yeah, that's a great question. So I tend to repeat biopsies every couple of years unless things aren't going like they should. So if I start a therapy, like THP in the first line setting for HER2 positive disease and they're progressing in 4 months, something's not right, I'm gonna rebiopsy that patient. Similarly, I've actually had 3 patients now who have had ER positive disease on first line AI CDK4/6, had 1 lesion growing and everything else looked great, biopsy that 1 lesion, and now it's HER2 positive. So certainly cancer changes its stripes in breast cancer about 20% of the time. And so I always tell my patients that what we pick is only as good as the information we've got, and so we have to have fresh information to make the best choice.
And I have a number of patients that I've followed that start out with hormone receptor positive, HER2 negative disease, and subsequent biopsies down the road will be hormone receptor negative, HER2 negative. How do you treat those patients? Do they behave like the triple negative up front, or?
Yeah, that's a great question. Molecularly, they have some differences from true triple negatives. They do tend to have more indolent disease, not quite like a triple negative, but I think that's really a sign that our therapies are good, right? I mean, so you had a hormone receptor positive cancer, you adequately treated it, you killed off a lot of cells, and what was left were the resistant mutants that didn't quite look the same, right? And so you do unfortunately kind of have to switch to start treating that patient more like a triple negative, but as you're seeing, our antibody drug conjugates, a lot of them are kind of going across hormone receptor positive and triple negative disease now.
Do you check those patients for PD-L1 status?
I don't check those patients for PD-L1 status. I do broad genomic profiling, so a lot of times we'll get something like that back, but I don't, for example, check for a Pembro, et cetera, because again, our benefit for Pembro is only in the first line. And so those patients that switch subsequently, we really haven't had any good positive data outside of first line triple negative disease that immunotherapy is benefiting breast cancer. So some of these other tumor types are still kicking our bottoms in terms of immunotherapy.